It's a great pleasure and privilege to be able to present the Aspirin arm of the Ascend trial on behalf of the Ascend Collaborative Study Group. These are my... So, aspirin use is universally accepted in the secondary prevention of cardiovascular disease. But for healthy individuals, the benefits from the avoidance of myocardial infarction and other occlusive events are largely counterbalanced by the increased risk of bleeding that we know aspirin causes. For people with diabetes, there's been major uncertainty for many years about the value of aspirin. And this is reflected in the very variable both use, as we've just seen in that opening question, but also in the guidance, the European guidance being somewhat more cautious typically than the American guidance. Furthermore, recent retrospective meta-analyses of older aspirin trials have suggested that aspirin might reduce the risks of cancer, with particular emphasis on gastrointestinal, in particular colorectal cancer, with effects appearing and increasing over time. So the Ascend study, the design is shown here, was set up to answer the vascular question, but has allowed us the opportunity to also address the cancer question. So 15,500 UK participants with diabetes who had no cardiovascular disease at baseline were randomized to 100 milligrams of enteric-coated aspirin daily versus placebo. The mean follow-up was 7.4 years, and there was almost complete follow-up for morbidity and mortality. As one might expect, there was some loss of adherence to the allocated aspirin over time, and also some drop-ins among those allocated placebo. So the results that you will see reflect the average difference in antiplatelet use between the two groups of 69%. The baseline characteristics were very well matched, as is shown here, and these were a well-treated for their other vascular risk factors, population of people with diabetes, as you can see here, with high rates of both blood pressure lowering and statin use, and low smoking rates, which are not shown here, and good glucose control. So if we look at the key outcomes, so we have a key primary efficacy outcome, a composite of non-fatal MI, presumed ischemic stroke or TIA, or cardiovascular death, but excluding any intracranial hemorrhage, and a primary safety outcome of major bleeding, which, as you can see here, is intracranial bleeding, sight-threatening eye bleeding, serious GI or other bleeds, and the other major bleeds were mostly severe epistaxis or severe bladder bleeding, and all of these were adjudicated and followed up and adjudicated and had to be severe enough to get admitted to hospital, be transfused, or were fatal. The key secondary outcomes for subgroup analysis was the extended outcome, including revascularization and gastrointestinal tract cancer. And I'm going to show you the cancer results first. So there was no difference in the risk of gastrointestinal cancers, as you see from the top line, and as you see from the bottom line, there was also no difference in all incident cancers, with over about 1,700 total incident cancers and a rate ratio of 1.00. There was no suggestion of effects on cancer beginning to emerge with longer duration of follow-up. So now let's turn to our primary efficacy outcome, and the placebo event rate is shown here at about 1.3% approximately per annum, with 9.6% by the end of the 7.4 years of follow-up. And what we see here is that there was a significant reduction in the risk of any serious vascular events, with 8.5%, 658 participants experiencing a first cardiovascular event with a hazard rate ratio of 0.88. If we look at the components of this significant reduction, we see that there's no significant heterogeneity across the components of the primary serious vascular event outcome, as shown here. And when we add in the revascularization, we remain with a hazard ratio of 0.88, a significant 12% reduction. We have done a variety of different subgroups, and I'm just showing you a very small selection here. There was no interaction by gender or 5-year vascular risk, and the subgroup by weight was done in light of the recent Lancet publication, suggesting a difference in exactly the opposite direction. And as you might imagine, most of our participants were over 70 kilograms in weight, and that is where all the benefit is seen. If we now turn to the bleeding, what we see is a 29% significant increase in the risk of any major bleed, as shown here, with again no significant heterogeneity across the different types of bleed. And most of the absolute excess shown on the right in serious gastrointestinal bleeds, a 0.5% excess, and in other major extracranial bleeds. So what we now need to consider is what the balance of the benefits and risks is among our participants. And to do this, we have subdivided our participants by their baseline 5-year vascular risk, as shown here. And so obviously the placebo event rate is rising in line with the 3 pre-specified vascular risk groups. But what is also important and of note is that the major bleed rate among those allocated placebo in this trial also rises with the vascular event rate. So that when we look at the impact of aspirin on that, what we see is obviously significant reductions in the risk of the vascular events, but also increases in the risk of bleeding. And what we need to compare is the difference in the height of these blue and green bars with the difference in the height of the red and yellow bars. And when we put those numbers in, we see that among the low-risk participants, we appear to avoid about 6 vascular events, but at the cost of about 3 major bleeds. But as you can see, there's substantial uncertainty around these estimates. Similarly, among the high-risk population, which represented about 17% of the participants, there were 11 events avoided at the cost of 10 major bleeds, but again, with major uncertainty. So to conclude, aspirin did not reduce the risk of cancer, and with no apparent risk emerging with longer follow-up, and longer follow-up with pre-specified analyses 5 and 10 years after the end of the scheduled treatment are planned. We did see both significant reductions in the risk of vascular events, but increases in the risk of major bleeding, so that the absolute benefits from avoiding a serious vascular event were largely counterbalanced by the increased risk of bleeding. And there was no group in which we could clearly define a benefit outweighing the risk. Thank you very much for your attention, and there's more detail available on the online publication.